So my name is Pete Reardon. I think I know pretty much everybody in this room, but for those of you who I don't, I'm one of the PGY5s here in the Emergency Medicine program. And I'm going to talk to you today about how we can optimize our care after return of spontaneous circulation, specifically what we can do in the first 15 minutes. Before I begin, I'd like to acknowledge several people who have been instrumental in helping me prepare for this talk. First and foremost, my staff mentor and faculty supervisor for this talk, Dr. Christian Yadav. Carrie Pouling sat down to talk to me about the logistics of our TOH protocols and the history behind them. Dr. Shane English for offering the critical care perspective. Drs. Dan Beliveau and Trevor Simard, who are cardiology fellows at Dalhousie and Ottawa. And Drs. Ben Hibbert and Michelle LeMay for offering their perspective from the interventional cardiology side of things. I'd like to thank Dr. Simeon Mitchell as well for providing some of the EMS data. And of course, my partner, Dr. Aisling Fitzpatrick, and my father, Dr. Mark Reardon, for supporting the home team. I have no conflicts of interest to disclose. And we'll start with a case. So picture you're working overnight. It's at the General. You get a patch that comes through. Previously healthy, 65-year-old male, collapses while up to the bathroom. Wife finds him on the floor, calls paramedics. The initial rhythm when they get there is PEA. There's a 45-minute total downtime between pre-hospital and emerge as he arrests and eventually obtains ROSC in ED. So, of course, the resus room goes wild. It's one of those moments everybody's high-fiving. You're feeling kind of like a superhero. Then the team turns to you and says, what do you want to do next? What are your next steps? Suddenly you feel all alone. You have lots of decisions to make. What's going to be my blood pressure target? Should this patient get a cardiac cath? Should I cool them to what temperature? And this is a crucial time period. In that early post-arrest period, what we do can impact patient outcomes. And so we're going to talk about our approach today. Objectives are to review the pathophysiology of the post-cardiac arrest syndrome. We're going to discuss our short-term resuscitation goals. We're then going to review the indications for cardiac catheterization and targeted temperature management. Then we're going to develop an algorithm for care of the ROSC patient that we can use in the emerge. What we're not going to talk about today is traumatic cardiac arrest. We're not going to talk about the arrest itself and ACLS protocols. And this is also not a comprehensive review of the critical care management of these patients. It's specifically what we can do in the emerge to help our patient. To start with the epidemiology, in Canada each year we see 35 to 45,000 sudden deaths from cardiac arrest each year, which is a rate of 1 in 1,000 for people over the age of 35 years. In Ottawa specifically, we have 500 out-of-hospital cardiac arrests, 150 get ROSC in the field, and 180 are transferred to the emergency with ongoing CPR. Now, once they get there and we get a pulse back, that's still not the whole battle. There's still a tremendous amount of morbidity, mortality that comes after that. And so overall, we see a survival to hospital discharge of 10%. Probably about similar chances to the surfer making it out of this barrel. Not quite. And so we can't change anything about the risk factors acutely. We can't go back and take away the arrest. But what we can do is improve our care in that early critical post-arrest period. Because we're dealing with absolute mayhem. The post-arrest syndrome is from this profound shock state, the most profound shock state. You're going from zero flow to low flow, and then finally dealing with the consequences after of global hypoxia to the tissues. Post-arrest syndrome, we can break down into 4 components. First, the persistent precipitating pathology. We then have post-arrest myocardial dysfunction, systemic ischemia reperfusion response, and post-arrest brain injury. And we'll talk about these in turn. So first, that persistent precipitating pathology. So what's lurking behind the arrest? Rounds of epinephrine, CPR, defibrillations. These haven't done anything to change the potential acute coronary occlusion massive PE, sepsis, overdose, and so you're still having to deal with the ongoing consequences of that. In terms of myocardial dysfunction, animal studies have shown us that regardless of a coronary occlusion or not, you still get a global hypokinesis. You don't have to have a blockage. In fact, ejection fractions have been shown to go from 55 down to 20%, and that'll last for usually up to 72 hours. For ischemia and reperfusion response, again, this is that global tissue hypoxia, which ends up leading to vasomotor dysregulation, so that vasoplegia we see, coagulation issues, immune system issues, adrenal suppression. Looks a lot like SIRS, that inflammatory response, and leads to the same common pathway of multi-organ dysfunction. And finally, we're going to have to contend with post-arrest brain injury. So that's the anoxia from the original insult, and then after, impairment in cerebral autoregulation, so we can get cerebral edema, and seizures, coma, and eventually death in some patients. So it's a big job for us. It's a challenge, and we're going to have a solid approach. The clock's ticking. And so this is going to outline our approach and what we can do. It starts with ROSC. We're then going to perform a primary assessment. We're going to think about our resuscitation goals. Think about if this patient is a candidate for cardiac catheterization, and also targeted temperature management or hypothermia. To begin with the primary assessment. So this is really asking yourself the question, what is that persistent precipitating pathology? What caused the arrest? This is what we do every day. We're thinking about acute coronary syndrome, which is about 50% of our arrest. Could be a respiratory or airway issue, metabolic issues, pulmonary embolism, the list goes on. And so our approach is not going to be that dissimilar to what we do with any patient in resus bay. Get an ECG. We're looking for STEMI or no STEMI. Full set of vitals with a temperature and a glucose. We're going to obtain more history. Did this patient have chest pain, diaphoresis, and then go down? Or did they have shortness of breath for 24 hours and syncope? Do they have risk factors that we can find, previous caths or coronary disease that are online in our EMR? Can't forget physical exam, bedside ultrasound, and of course other investigations, our initial labs, chest x-ray, and directed ordering for things like toxicological causes. But we may come to a point where we've done all that and it's still unclear. We don't know what caused the arrest of this patient. And then the alarm starts beeping, we look over, and the monitor is showing these vitals. What are you going to do next? Picture this is your patient, the patient at the general, overnight in the resus bay. How are you going to manage those vitals? So moving on from primary assessment to our resuscitation goals. And this is dealing with our basics, the ABCs, or in this case, circulation, airway, and breathing. This is a necessarily fluid concept. You may identify things in your initial primary assessment, like a life-threatening airway issue, a breathing issue like pneumothorax caused by the CPR, and you're going to have to address that first. So your priorities may change. In this patient, circulation comes first. We're not going to spend too much time on airway. We know that a lot of these patients come in now with supraglottic devices or LMAs, and that's fine. The goal is to manage our oxygenation, our ventilation. If you have time, change it out for an endotracheal tube because it may help you manage those goals. But if the patient has a ST elevation on their ECG and they're going to go off to the cath lab and they're ventilating fine, don't delay their transfer. In terms of blood pressure, the Canadian Cardiovascular Society released a position statement for the post-arrest patient in 2017, and what they recommend is a MAP of at least 65. Where do these targets come from? You might ask yourself, this is a patient with low flow state, with a damaged brain, and maybe we need more blood flow, higher MAP targets. And in fact, some of the observational studies will show that. MAPs of over 90, leading to better neurological outcomes, survival, better cerebral oxygen saturations. But the problem is that some of these studies are with bundled care, and you can't tease out what the components are having the biggest effect. and also they're retrospective, they're observational. But what we do know is that hypotension is bad. We know that sustained hypotension is worse than episodic, and it's a dose-response relationship. The lower that blood pressure goes, the worse outcomes we're going to have. So we want to avoid hypotension at all costs. Now, in terms of balancing these things and finding your MAP target, we have to remember our basic principles. In that, MAP is not perfusion, pressure isn't flow. Flow is what we're trying to get. We're trying to get more perfusion to our tissues. So you need to examine your patient. Don't just pick a number and shoot for it. Put your hands on the patient. Are their legs cold and mottled? Are they producing urine? These are signs that perhaps the patient is perfusing or not perfusing. Clinical history is important too. Is this patient known to be poorly controlled, have poorly controlled hypertension, comes into the emerge repeatedly with very high blood pressure, is non-compliant? This might be the patient that we need higher blood pressure targets. And the literature is going more and more in that direction, that we should be personalizing our care for patients. Now, the tools that you have to manage it are the basics. Again, we're talking fluids, vasopressors, ionopressors, and concurrent management of other things like rapid AFib, anemia. Talking fluids first. This is a paper from the JAMA Rational Clinical Exam series a few years ago. And it's a great resource in terms of thinking about tools that we can use to assess fluid responsiveness in our patients and guide our fluid management. Dr. Ariel Hendon's going to be giving a grand rounds in a few weeks on this, so I won't spend too much time, but you need to pick your method and go with it. To simplify it, it does vary on clinical context. Do you think this patient is cardiogenic shock from an MI? Do you think they're a massive PE with right heart strain? So you need to decide and keep that in mind. You need to perform some sort of volume status assessment, but if in doubt, small boluses are best. So I just said that 50% are going to be acute coronary syndrome, and the vast majority of patients from the arrest alone are going to have a global hypokinesis. So best to start low. And then, of course, reassess. Now, sometimes fluids aren't going to cut it. And maybe we need to move on to vasopressors. So I want you to take a moment, turn to the person next to you, and discuss what your strategy would be. Think about our patient. Hypotensive, we've given a few boluses. What are you going to reach for next? So I'll give you 2 minutes. All right, so maybe we'll rein it back in. I lied. You don't have 2 minutes. So, show of hands for the groups. How many people would reach for norepinephrine first? Okay. How many for epinephrine? How many for vasopressin, milrinone, dobutamine, any other agent? Awesome. Okay, so most hands for norepinephrine. We'll talk about some of the recent evidence. So this is from the Journal of American College of Cardiology earlier this year. It was a randomized trial looking at epinephrine versus norepinephrine in cardiogenic shock after MI. It was a double-blind RCT looking at a primary outcome of cardiac index, which is cardiac output over body surface area. They had a primary safety outcome of refractory cardiogenic shock. They randomized 57 patients, and they found that the cardiac index was similar between groups at 72 hours. but they found a higher rate of refractory cardiogenic shock in the epinephrine group. And in fact, the trial was stopped early by the Data Safety Monitoring Board because of it, and that's why the numbers are so small. It's because they found a rate of 37% of refractory cardiogenic shock in the epinephrine group versus 7% in the norepinephrine group. Now, of course, this was a small trial. It was stopped early. The epinephrine group did have a slightly higher lactate at the time of inclusion, but bottom line is that there were similar effects in arterial pressure and cardiac index, but a higher incidence of refractory cardiogenic shock with epinephrine use. Another study, this is from 2018 as well, earlier this year, by Leopold and colleagues, and they did a meta-analysis of patient-level data. So 16 studies, over 2,600 patients, and compared survival with epinephrine use versus other agents. Now, this was mixed etiology. It wasn't after solely MI like the previous study. And what they found was in 37% of cases, epinephrine was used, and mortality overall, 49% for the cohort. They found overall odds ratio of increased mortality associated with epinephrine of 3.3. Afterwards, they performed some adjusted analyses and then did a propensity match. So took 300 patients, matched them very closely, and they found an increased odds ratio, 4.2, showing higher mortality with epinephrine use versus other agents. Our Cape position statement, this is the VICE guidelines a few years ago, has strong recommendations for norepinephrine both in cardiogenic shock and undifferentiated shock. So overall, we're going to recommend a MAP greater than 65. Remember, you may need higher MAP targets for decreased perfusion or for poorly controlled hypertension at baseline. We're going to use fluid boluses initially and then titrate a norepinephrine infusion. If you do feel you need some inotropy after that, perhaps a severely depressed ejection fraction or poor perfusion despite high norepinephrine doses, we can reach for dobutamine. But again, most of the time this will be done further down the line in either the CCU or the ICU. On to breathing. And we'll talk about oxygen first. So we know inherently that hypoxia is bad. Hypoxia is associated with higher rates of rearrest, increased mortality, but there's been more and more evidence lately that hyperoxia is bad in multiple different settings, but also cardiac arrest. And so we need to think about, on the other end of things, that hyperoxia may be causing increased free radical formation, oxidative stress on our cells, and worsening outcomes. And there's observational data to back that up. Significant odds ratios reporting poor neurologic outcomes, decreased survival among patients with hyperoxia. This is a figure from Helmerhorst and colleagues in 2015. It was a Dutch registry of over 5,000 cardiac arrests. And what we have on the bottom on the x-axis is the partial pressure of oxygen in on the arterial blood gas. And on the left, on the y-axis, we can see the probability of death. And what we notice is that it's a U-shaped curve. So although hypoxia is bad, there seems to be a dose-response relationship where hyperoxia progressively worsens the survival. Now, the big problem is that there's a danger between interpreting our saturation and guessing the arterial PO2. So on the low end of the spectrum, they correlate pretty well, as in we can guess where it's going to sit. But as it gets higher and higher, specifically over 98%, you can see in this table huge jumps in the PO2. So our goal really is to maintain normoxia, a SAT of 94 to 98%, and be very careful as you see the SAT go over 98%, especially a SAT of 100, because you have no idea where that PO2 is sitting. On to ventilation, or our CO2 goals. The pathophysiology of this really has to do with its effect on our cerebral blood vessels. So looking at partial pressure of carbon dioxide on the bottom, and over on the left, cerebral blood flow. It's a sigmoid-shaped curve, and over on the right, as the CO2 goes higher, our cerebral blood vessels dilate. So although we get more blood flow, which can be potentially beneficial, it increases cerebral blood volume, potentially increases ICP, and that can lead to deleterious outcomes as well. On the left side of things, as the CO2 decreases, we get a vasoconstriction, which can lead to ischemia and cell death. Now, there's conflicting evidence. We were saying before that there's an area of low flow and cerebral anoxia. And so in theory, a mild hypercapnia with increased blood flows can be beneficial. But meta-analyses have shown us that normal carbia is best. Again, it's hard. This is retrospective data. Helmer, Horst, and colleagues did a similar thing with PCO2 on the bottom and probability of death on the left. And again, we're seeing that U-shaped curve. So again, we want to maintain a tight range. Hypocapnia is bad. Hypercapnia is bad. Now, the interesting thing is the nadir of this curve, and this is arterial CO2. The bottom part of that is 48, showing the high survival with a mild hypercapnia. Something to think about. Now, of course, we need to consider that most often in the emergency we're using end tidal. The RT is going to hook that up for you. You're going to get it in real time. You don't have to wait for a blood gas to come back. And we need to remember that end tidal is not the same as arterial CO2. And that's because of dead space ventilation. Naturally, in everyone in real time, we have areas of the lung that are ventilated but not perfused as well. And so there's a mismatch. Certain conditions can worsen this, like pulmonary embolism in this figure, low flow state. But roughly, for most people, we can guess that the difference between the two is going to be about 5 millimeters of mercury. So for our ventilation targets, we're going to monitor end tidal CO2. We're going to expect a difference between our end tidal and our blood gas, what the patient is really experiencing. And if you're concerned there's a significant VQ mismatch or the numbers don't make sense, get a blood gas and check it. We're going to titrate a normal capnia, which is an end tidal CO2 of 30 to 40, or a PCO2 of 35 to 45. So to review our resuscitation goals. We're shooting for a MAP 65, but we're going to monitor perfusion. We're going to control the airway, titrate SATs 94 to 98, and an end tidal of 30 to 40. So back to our patient. Clock's ticking. We did our primary assessment. We didn't identify any immediate cause that we could pick out. We saw decreased LV function on the echo globally, so perhaps not telling us as much. We saw that hypotension on the monitor, the tachycardia, and so we gave 2 fluid boluses. We started with small ones. They didn't respond to the second, so we started norepinephrine infusion. It's now up to 10 mics a minute, and our map's good. We're happy. Good perfusion. We've intubated. We've exchanged that supraglottic device for an endotracheal tube since we had time, and we titrated the SATs. They're now 96, and tidal is 38. So then we get handed this ECG. So I'll give you a moment to interpret that. And what do you think? If I were to tell you that I was upset with that ECG, that this makes my life harder, what are you thinking? Parks, what do you think? Why am I upset with this ECG? Because there's no STEMI. Exactly. STEMI's easy, right? STEMI. Call a code STEMI, and things move along. What about this patient? Do they need a cardiac cath? The Canadian Cardiovascular Society, again, their position statement from 2017, recommend that in out-of-hospital cardiac arrest patients with STEMI, immediate angiography and primary PCI should be considered. That's a strong recommendation. But what if our patient doesn't have that? So a few studies have looked at this, as Millen and colleagues in 2016, looking at out-of-hospital cardiac arrests who received angiography. And they were looking at rates of revascularization for culprit lesions divided up between STEMI and no STEMI. For STEMI patients, 72% were revascularized. For no ST elevation, a third were still intervened on. So still a substantial amount. Wilson and colleagues in 2017, now they divided up their arrest based on shockable, non-shockable rhythms. And the group that you think would have the least amount of intervention are non-shockable rhythms, no ST elevation on the ECG, rate of intervention of 25%. So although that was the lowest in the cohort, still a quarter of them are getting revascularized. And so maybe we should be intervening more on these patients. And some centers are doing this. This is a study published just last week in the Journal of American College of Cardiology, Cardiovascular Interventions. It's the experience from the HACOR registry. So this is a group in Hanover, Germany that wanted to look at the effect of their aggressive cardiac arrest protocol. It was a prospective observational study. Their novel algorithm included routine angiography for all patients. They cooled everybody to 32 degrees, and they had an aggressive protocol for supportive care in the ICU. The primary outcome was 30-day mortality, and they also looked at neurologic outcomes. Now, this is the figure from their study. It's a little bit busy, so we'll break it down. Essentially, they had a three-pronged approach between nursing, the cardiac intensivists, and also anesthesia. The nurses focused on getting an early ECG, getting some blood work started, and supportive care. Anesthesia would intubate, manage the airway. They would put in an arterial pressure monitor and also establish 2 large bore IVs, or if not, a central access if they really needed it. From the cardiology perspective, they were monitoring with echo and preparing for cardiac catheterization. Again, routine angio for most patients. They also cooled to 32 degrees. And so what they found was 233 consecutive patients that they treated from 2011 to 2015, mean age of 64 years, and a witness arrest in 81%. 3/4 were shockable rhythm, about half were STEMIs, and cause of arrest they determined to be around half being MI, dysrhythmias in 39%, PEs made up 3%, and other causes in 8%. They did diagnostic angiography in 95% of cases, because there was a stopgap in the middle where, as they're following their flow, they could decide, hey, this patient dropped with a headache first, perhaps is subarachnoid, we can do a CT head. They had atypical chest pain with shortness of breath, and they've had a PE in the past and non-compliant with their anticoagulants. And so maybe we could do a CTPE. So not everybody got diagnostic angiography, but 95% did. They did PCI in 56% of those patients. In terms of STEMI versus no STEMI, in the STEMIs, 62% were revascularized. And the no ST elevation on that ECG, still half, 52%. And what they found was an overall mortality of 41%. So pretty good. But we need to consider that in context. They needed a comparator. And so what they did was they looked at another contemporary trial in cardiac arrest and compared the mortalities. And so this is the TTM, or Targeted Temperature Management trial from 2013. It was a trial looking at hypothermia post-arrest, cooling to 33 or 36 degrees. And we're going to talk about this later when we address hypothermia. But they found overall a mortality of 44%. So in this study, 41%. Well, they're pretty similar. But in fact, when they took the inclusion criteria from the TTM study and applied that to their patient population to make it more comparable, they ended up with a mortality of 27%. So perhaps a signal to more improved benefit with their aggressive protocol. Now, of course, we need to consider it's a single center, non-randomized study. It's bundled care, so we don't know which part is having the effect, but it's certainly hypothesis generating. This is something new that they're doing with routine angio. Other studies would support this. So survival with early angiography. The first study by Spalding and colleagues in 1997, this was published in the New England Journal, had an odds ratio of 5.2 for improved survival. And this is patients with no clear cause of their arrest. Other studies have shown similar benefits in terms of neurologic outcomes, survival. So we'll talk about our protocol for a moment. This is the TOH protocol, which begins first with, does the patient have a STEMI? If they do, call a code STEMI, and the process gets initiated. Now, if they don't, we need to consider, is there a likely cardiac etiology? And if there's not, we'll go to the ICU. And if there is, we're going to call code ROSC. But think about our patient. Our patient was 65 years old, no past medical history, drops in the bathroom, his PA arrest, no ST elevation on the ECG. Is he a clear likely cardiac etiology? Should we call a code ROSC? Should we send him to the ICU? And what if we're at the general, like in this case? And you call a code ROSC, you're overnight, get the junior resident covering cardiology overnight, and the resident from race who's on ICU. They're then going to talk to their staff, who may decide it's undifferentiated, we're over the phone, let's just hold them overnight, they look stable, and we'll have a look in the morning. And so this is a delay potentially for patients who may have a coronary occlusion that we need to revascularize. So based on the evidence, I would propose that we start with ROSC. Again, STEMI, no STEMI. If there is, we'll call code STEMI. And if we don't, consider that clear alternate cause. If there is, we'll send them to the ICU. For sure, no problem. This is our clear subarachnoid PEs. But for the patients who don't have a clear cause, we'll call code ROSC on all of them.
Attention, code STEMI, emergency resetting.
Done. They've been listening. And now, after you call a code ROSC, if you're at the general, I would simultaneously call the Heart Institute. Speak to the CCU fellow. Maybe this patient deserves to be considered for cardiac cath. Now, there are considerations for CT head, CTPE, because again, some of these patients, like ours, completely undifferentiated. And before you send them to the cath lab where they may get blood thinners, you may want to make sure that they don't have a subarachnoid. And so, for those patients, we may proceed with a CT head, CTPE, but if after all that, think you've done your primary assessment, you've examined the patient, you've sent off some labs, you've done an X-ray, you've done an ECG, you've done a bedside ultrasound, you've done a CT of the head, CT of the chest, and you still have no clear cause, what's the elephant in the room? And we know that time is muscle. So back to our patient. No ST elevation on the ECG. We've done our primary assessment, our resuscitation. We've called the code ROSC and we paged the CCU fellow over at the Heart Institute, and they've given us the green light. Send the patient over. But they want a CT first. So you do a CT head, CT pulmonary angiogram, no clear cause of arrest. Then you think to yourself, is there anything else that I want to do? What about hypothermia? And so just to poll the room, show of hands, how many people are not cooling their arrests? How many people are choosing 36 degrees? How many people 34 or less? We have a shy or tired group. Or how many people don't know or not sure? Okay, awesome. Okay, so we're going to talk about it. So hypothermia, the proposed benefit, we have a decrease of that ischemia reperfusion response. We're decreasing the blood-brain barrier permeability and improving cerebral microcirculation, so perhaps protective to the brain. And also, we're reducing that cerebral metabolism, so up to 6 to 10% for each degree that we drop. So perhaps protective in that way. Now the downsides, of course, we've heard about metabolic derangements, insulin resistance leading to hyperglycemia, coagulation issues from platelet inhibition, and hemodynamic instability, specifically bradycardia. So something to consider as well. Now, the hype all comes from 2002. 2 big trials were published. There was the hypothermia after cardiac arrest trial and the Bernard study. And what they found, it was 2 small studies looking at VT, VF arrest, and very early cooling. They cooled to 32 to 34 in one study and less than 34 in the other. Again, early cooling, and the Bernard study was started in the ambulance putting ice packs on. And they found a significant improvement in survival, and specifically neurointact survival. And so everybody was pumped up. Here we go, beryllium's out, but here's something we can hang our hat on, hypothermia. Then along came the TTM trial. So this was published in 2013, looking at 36 versus 33 degrees. It was out-of-hospital cardiac arrest, randomized trial, looking at a primary outcome of all-cause mortality. Adult patients, obtunded patients, and they looked at any presenting rhythm, so not just shockable rhythms, VT, VF arrest like the original trial, but they included PEAs, asystoles. So they included just under 1,000 patients. In terms of mortality, no difference. Neurointact survival, no difference. In terms of adverse effects, bleeding, infection, arrhythmias, no difference. So the bomb went off. Is anybody believing in hypothermia anymore? Is this out? Well, we have to consider some of the limitations. So TTM, again, they expanded their inclusion criteria. So they included the PEA and the asystoles, which we know have a poor prognosis. So perhaps you're diluting the effect for the patients it may actually impact. There was delayed cooling, 10 hours from ROSC on average, and faster rewarming times, which has been shown in the literature to be deleterious to outcomes. And finally, it was designed as a superiority trial. Superiority trials compared to equivalence or non-inferiority have much smaller sample sizes. To think about it, you need a much bigger number of patients to tell, is there a small difference or are they the same? And so saying that there's a lack of superiority is not the same as saying that those two treatments are equivalent. Now, it's important to note that 36 degrees is not no intervention. And in fact, in both arms of this study, the groups were actively cooled. Internationally, most guidelines have adapted to increase that threshold, and that we can choose anything up to 36 degrees. But recognizing that there's weaker evidence for the higher temperatures, for the non-shockable rhythms, and better evidence for shockable rhythms and going lower. However, perspective from the Canadian Critical Care Society, this was published in 2016, they looked at the evidence, and in fact they say we should be cooling between 32 to 34 degrees. That's where the strongest evidence lies, that the TTM trial had some weaknesses, and that, in fact, saying that that 33 is not superior doesn't mean that we should throw the baby out with the bathwater. So I spoke to Dr. Shane English about his opinion. He's our local neurointensivist. And what he had to say was he continues to target 34 as a rule. And the TTM, the limitations in it, are too much to refute the other evidence that we've had, specifically the Bernard trial and the Hockett trial. Over at the Heart Institute, we still have a randomized trial going, the Capital Chill, which is randomizing from 34 degrees or 31 degrees. So between a mild and a moderate hypothermia, and we're not targeting the higher temperatures. Practically speaking, I'm sure it's entering your mind, in the eMERGE, we're time limited. We're not spending hours with these patients, closely titrating the temperature, and also that patients arrive hypothermic. So in the TTM trial, the presenting temperature, 35.3 degrees on average. So what I see as TTM in the eMERGE, really we need to measure the temperature in some fashion. Put in the bladder probe, it's in a Foley catheter, or a nasopharyngeal probe, see where we're starting from. We can put ice packs on as needed, easy enough to put them on, neck, groin, axilla, and we have a goal temperature of 34 degrees, but get the process started. We're going to need to know how to control shivering, but this is easy. These are the drugs that we're very comfortable with, that we use regularly. It can be any opioid like fentanyl, propofol, benzodiazepines, anything that you're comfortable with. Most importantly, we need to avoid hyperthermia. Contraindications to consider: refractory shock, uncontrolled bleeding, severe infection. These should make you pause. And of course, if the patient's following commands. So back to our patient. We ask a Foley to be inserted, bladder temperature is 35 degrees. So we put some ice packs on to initiate cooling, and the patient transferred to the Heart Institute for further care. Our time is up. So to review, this is the algorithm that we've covered today. Perhaps this can serve as a guide to help us in that first 15 minutes of the resuscitation. Because again, this is a critical time period for our patients, and early and effective care can make a huge difference to outcomes. Thanks very much for listening. I'll take any questions.